Welcome to the Health Workforce Technical Assistance Center's webinar series. This webinar is entitled Strategies to Expand Access to Oral Health Services, Emerging Models and Workforce Innovations. And it was presented by Jean Moore, Margaret Langelier, and Cynthia Wides on July 28, 2016. Hello, my name is David Armstrong, and I'm the Director of the Health Workforce Technical Assistance Center. Today's presentation focuses on strategies to expand access to oral health services. But before we get started, I would like to introduce today's speakers. And for those of you who missed our previous webinars, they are all available on our website at healthworkforceta.org. Jean Moore is the Director of the Oral Health Workforce Research Center located at the New York Center for Health Workforce Studies. Margaret Langelier is the Deputy Director of the Oral Health Workforce Research Center, and Cynthia Wides is a research analyst at the Health Workforce Center located at the University of California, San Francisco School of Dentistry. At this point in time, I'm going to go ahead and turn the event over to our presenters. After the event, you will have an opportunity to ask questions using the chat panel on your screen. Also, when the event ends, you will be directed to a short evaluation survey, so please take a few moments to provide us with your feedback.
Good afternoon, everyone. We're really happy to be here. So we want to say a little bit about the Oral Health Workforce Research Center. It's relatively new, and we hope to help you understand who we are and what we do. Next, we want to make the case for why oral health research is so important, and in our case, oral health workforce research in particular. Next, we'd like to cover some of the strategies that we're looking at and studying that we think has the potential to improve access to oral health services. And the presentation today will focus on findings from the Oral Health Workforce Research Center projects, looking at increasing access to care in new settings, expanding roles for the oral health workforce, and creating bridges between primary care and oral health, which is also a really exciting opportunity. And we'll also describe some of the state and local initiatives that we're aware of that have increased access to oral health services. And then finally, using research findings to inform oral health programs and policies. As you may know, health workforce research centers are supported by HRSA, specifically the National Center for Health Workforce Analysis. And there are a number of different centers in different locations with different focus. So UCSF has a Health Workforce Research Center focused on long-term care. George Washington and UNC Chapel Hill both have workforce research centers focused on the flexible use of workers, and I think we all agree that's pretty timely given health reform efforts and some of the transformations going on and the new needs for workers. University of Washington has a center that looks at allied health. So the Center for Health Workforce Studies at Albany, in addition to having the Oral Health Workforce Research Center, we also have the Health Workforce Technical Assistance Center, lucky for us because they're sponsoring this webinar. And finally, one of the more recent workforce research centers is based out of the University of Michigan, focused on behavioral health. So as I mentioned, our center is based at the Center for Health Workforce Studies, and it's actually a partnership between our center and UCSF. Beth Mertz is a researcher who we collaborate with, as well as Cynthia Wides, who is going to be presenting shortly. Again, our center conducts research aimed at improving the oral health of the nation's population, and I think we all recognize that we need an available, competent, well-distributed workforce to meet unmet need for oral health services, and our studies are really aimed at looking at where the need is, what the strategies are, and really helping to make people aware of what the issues are and what the potential strategies might be. So this gives you a list of the studies we completed last year. We looked at dental hygiene scope of practice across states. We developed a scale back in 2001 that allowed us to quantify the scope of practice for dental hygienists. So we updated our assessment of dental hygiene scope of practice so that we could better understand what had changed since the last time we did it in 2001. Another study that we did was comparing utilization of Medicaid dental services in a couple of different states with very different adult dental benefits, one being a fairly limited benefit and the other state progressive or with many allowable services, and just trying to understand differences in utilization patterns between the states with different benefits. We completed a study of the dental assistant workforce in the U.S. We completed case studies of 8 federally qualified health centers that integrated oral health and primary care services. And we completed a 4-state case study of delivery models for dental care services in long-term care settings. Currently, projects that are currently underway is we are looking at the contribution of underrepresented minority dentists in reducing oral health disparities in the country. We are studying the provision of oral health assessment services by physician assistants. We are in the process of updating the scope of practice index scale. So in year 1, we actually rescored scope of practice. This year, we're taking a closer look at the index we use to update that. We're also looking at the impact of dental residents and students, as well as dental hygiene and dental assistants, dental assisting students on service capacity at FQHCs. And finally, we conducted a series of teledentistry case studies where we wanted to learn more about the use of technology in the delivery of oral health services, particularly as it related to underserved populations. So why is oral health workforce research so important? One big reason is the increasing evidence of links between oral health and physical health. Dental caries and periodontal disease are associated with any number of medical conditions, including coronary artery disease, diabetes, preterm birth and infant mortality, inflammatory diseases such as rheumatoid arthritis, systemic infections in patients with implants and joint replacements, substance abuse. And we know that dental caries are preventable and transmissible, and periodontal disease is often preventable with proper care. So despite the fact that we know these relationships exist, we also recognize that medical and dental services tend to be siloed. They tend to be found in different delivery systems with not a lot of communication between systems. You know, electronic medical records don't often interface with electronic dental records, and referral networks between physicians and dentists tend to be limited. In addition, they tend to operate in different insurance systems, which further complicates it. We think that the one important exception are federally qualified health centers. So these are safety net providers that are required to either provide or refer patients needing oral health services. And most recently, HRSA has made a considerable investment in supporting FQHCs to either expand the provision of oral health services or get the resources they need to begin providing it. So I think we recognize that there are oral health disparities, and they are quite challenging. You know, in some instances, they're population-specific. So there are certain groups that typically are underserved, lack access, you know, including people in lower socioeconomic categories, minorities, including American Indians, children, people with special needs, the elderly. In addition, there are geographic disparities, and access tends to be more limited in rural areas and inner-city urban areas. I think we all agree that uneven access to oral health services is a public health crisis. I think that Diamante Driver, as most of you know, was probably one of the things that really brought attention to the problems we face and what horrible outcomes can occur. So dental caries are the most common and preventable chronic disease of childhood, and poor oral health affects well-being, productivity, lost time from school or work. It can disrupt academic success or employment. And we're beginning to see an increasing number of costly emergency department visits for oral health problems, many of which could have been addressed in ambulatory settings if it had happened earlier. Some of the key access barriers, one that we've seen a great deal is oral health literacy. So I think at times people don't always appreciate the value of preventive care and the fact that preventive care can avoid or prevent costly restorative services, or the value of avoiding problems. Another access barrier is oral health provider availability. Sometimes providers are in short supply. Sometimes the supply seems adequate, but they're not where we need them. Or treating the patients who need the services, such as Medicaid patients. Also, a barrier can be scope of practice limitations, and we'll hear more about that from our work looking at scope of practice for dental hygienists. And resources to pay for needed care, and again, I'm sure everybody recognizes this, but you know, honestly, even those with dental insurance may be subject to high copays or limited service coverage. There's no benefit for seniors under Medicare. And again, limitations on Medicaid dental coverage, which, as we know, varies state to state. So now I'm going to turn this over to Margie Langelier, who's going to talk about some of the key themes from our research and talk about some of our studies. Margie?
Good afternoon. So today we're going to talk about some of the strategies that are being employed across states and in localities to increase access to oral health services. This list is by no means exhaustive, but it does focus on workforce initiatives and program initiatives that have been of special interest to us as an Oral Health Workforce Research Center. Cynthia and I are going to present to you sort of a superficial review of some of the projects that we've completed through the Oral Health Workforce Center and also through other grants that we have to do oral health research, specifically in states that are struggling with workforce policy initiatives to increase access. This afternoon, I'm going to talk to you about a few things. Integrating oral health and primary care services. There's a great interest at the federal level and in educational communities for interprofessional education and for integrating actual service provision in primary care settings and in dental settings as well. Increasing the availability of oral health services in public health settings is another very common strategy of states. Allowing dental hygienists to work in public health settings has proven to be quite successful and has affected outcomes, particularly for children. Using team-based approaches to oral health service delivery in days now when value-based care is really a strong emphasis, using teams and allowing professionals to work at the top of their scope of practice is becoming a very common strategy. Some of the workforce strategies in oral health are quite interesting. There are training programs now working with primary care medical or health workforce to learn about oral health assessments so that they can provide that in their clinical practice and refer for oral health services. Expanding functions for dental assistants and dental hygienists has been a strategy for probably at least the last 10 years, if not the last 20 years. And now, more recently, we're seeing the emergence of new categories of oral health workers. I'm sure many of you have heard about dental therapists, community dental health coordinators, public health dental hygienists, advanced practice dental hygiene. And last but not least, we're going to address a few local solutions to oral health access issues. One of our beliefs, and the belief of many in the field, is that local solutions to address local need are the most effective at meeting unmet need. So the first area is increasing access to services in public health settings. Creating new access points has proven to be very important in improving access to services. So currently many states allow for mobile dentistry, for portable programs in schools, in WIC programs, in correctional facilities, and in rehabilitation centers. We are today going to present on federally qualified health centers and on oral health services in long-term care. So the first study that we did in our most recent year was we did case studies of 8 FQHCs in 9 different states to understand their strategies for integrating oral health in primary care. As Jean mentioned before, FQHCs are mandated to provide oral health services for children and preventive services for adults, either through direct provision of services or through referral. And FQHCs are really very uniquely positioned to provide integrated patient-centered health and oral health services. They have wonderful opportunities to innovate because they have access to a wide array of multidisciplinary providers, making referral between health and oral health quite possible. It's important to recognize that many FQHCs co-locate their dental services with their primary care clinics. In fact, about 80% of FQHCs are now directly providing oral health services to patients. However, we have to remember that co-location does not necessarily mean integration. It's quite possible for dental clinics and primary care clinics in an FQHC to still be operating in silos where there's limited information exchange. So what did we find in the case studies of FQHCs? We found that, in fact, they had many opportunities to use innovative workforce models in their clinics simply because many of those models are enabled in state legislation and regulation to work in public health settings. In fact, some of that legislation and regulation actually specifically states that a particular percentage of the services provided by those workers must be to Medicaid eligible or low-income populations. So in the FQHCs that we visited, all had fixed clinics. Many also had mobile and portable services. The traditional dental team was predictably dentists, dental hygienists, dental assistants. Those dentists were mainly general dentists, although in several of them there was a cadre of specialty dentists that were also available to the patients at the FQHC. The oral health team innovations included public health dental hygienists, community dental health coordinators, which is similar to a community health worker or a patient navigator in oral health, dental therapists and dental hygiene therapists. Many of you may have heard about the new workers who now provide basic restorative services in a few states, and expanded function dental assistants who've been trained in everything from restorative services to orthodontic services and a number of other functions. In FQHCs, there were also many primary care providers, including NPs, PAs, and doctors who were helping to extend the oral health team. Another strategy that FQHCs were using to improve their capacity to provide oral health services to meet very high demands from the patient population was participation in dental residencies and student externship programs. The Commission on Dental Accreditation now requires that all dental students complete a certain amount of clinical rotation in community settings. For that reason, FQHCs are being engaged as rotation sites for dental students and also for dental residents. And this is proving to be beneficial on many fronts. They're finding that residents enjoy working in public health and really seeing the need for oral health services in those settings. One of the things that dental residents explain is that they get more experience with providing certain restorative services in public health clinics than they do in the private practices where they were rotating, simply because the need is so high. And on the other side of the coin, it's been very beneficial to FQHCs who have the opportunity to work with students and residents and to actually recruit from the cadre of those students and residents who rotate through their programs. So what we're seeing, at least anecdotally, is that some FQHCs are having much less difficulty now recruiting dentists to work in their clinics because they can offer loan repayment, they offer a very good entry salary in many cases, so these rotations have been quite beneficial. So how do FQHCs integrate primary care and oral health? Again, we found this to be very individual and very dependent on the structures, the information systems within the FQHCs, the patient population within the FQHC, but I'll share with you a few of the things that we found. We found that integrated or interoperable electronic health and dental records are essential in achieving integration of primary and oral health services. They're a means of communication between primary care physicians or NPs and PAs and dentists and dental hygienists. There are many primary care clinics now that are doing an oral health assessment at medical intake. The primary care clinician will ask about the last dental visit, whether or not the availability of an oral health provider, and will also do an oral examination. Oral health providers, on the other hand, are doing blood pressure checks and taking health histories at their dental visits and including them in the medical and dental record for the patient. In one FQHC, they were actually involved in a demonstration project where they were doing A1C levels on patients that appeared to have a risk for diabetes because of the presentation with periodontal disease. One of the strategies that FQHCs were using is requiring that all patients in the dental practice also be primary care patients. This allows the FQHC to actually become the comprehensive health home. It allows referrals back and forth between the two practices and was working quite well as far as being able to address overall health outcomes for all patients. Some are also scheduling oral health assessments by dental hygienists as part of their annual pediatric well visits. When a child is coming in, for instance, for a one-year checkup, a dental hygienist will be scheduled to come to the pediatric clinic and actually do the oral health assessment. In some places that had become so routine that parents were refusing to leave if the dental hygienist was not yet there because they really wanted their child to have the assessment. Another strategy is to use dental hygienists to provide services in primary care practices that are affiliated with the FQHC, so that a dental hygienist might be at a community primary care practice, provide preventive services in that medical practice, and refer back to the fixed dental clinic at the FQHC for further services if treatment is needed. So, Cynthia, I'm going to turn over the slides to you for your presentation on long-term care.
Thank you. Good afternoon, everyone. So a few words about the study we actually conducted was a mixed method study conducted by Dr. Elizabeth Mertz and myself, Cynthia Wides, at UCSF. We examined 4 states, California, Minnesota, North Carolina, and Florida, and did extensive literature review, policy analysis, as well as conducted key informant interviews with providers, long-term care facilities, administrators, as well as experts at the national level and at the state level in oral health policy. So the findings of our study were largely stratified into 2 really big categories. The first is really state-specific, highly policy-informed, things that, hinge a great deal on individual state scopes of practice for various provider types, reimbursement, availability, certain demographic points about the population. Medicaid reimbursement policy specifically was a really big indicator of access to care for residents of long-term care facilities. And the other kind of large bucket of findings that we had were at the national level, things that really applied across states, across populations, and didn't necessarily hinge on individual state environments. So that's a great deal of what the focus we'll be talking about today is largely going to be looking at these more national level things. And so with that, one of the first key findings or reasons for the study at all, rather, is that at some point in their lives, almost half of people who are over age 65 will reside in a long-term care facility. So this is, especially with the baby boomer population, continually aging, something that's really going to touch almost every American household on some level. And residents of long-term care facilities or those receiving in-home care have much higher risk of poor oral health status than the general population. So this next slide here is going to take a look at some of the key findings of our study in terms of the differences between dental care delivery in a long-term care setting versus to the general population. And overall, the overarching finding is that dental care in long-term care facilities is different and more difficult than it is to the general populace. These patients are frail, often elderly, cognitively impaired. They require additional supplies and medications in order to help them stay still sometimes during an appointment or to ease pain. They are a higher aspiration risk. And even asking a patient, some of these patients to do a basic thing like hold their mouths open or lean back so that the dentist or hygienist can access the back part of their mouths. Some of these patients can't do that unassisted. For that reason, additional staff and additional time are needed to keep the patient safe, as well as to allow the provider to practice ergonomically. There's specialized equipment required. Some of these patients are wheelchair-bound or bed-bound and, or may have very hunched back and be unable to lean backwards. They are at great fall risk. Moving them from a bed to a chair is not, let alone a dental chair, is not always an easy or straightforward thing. And furthermore, most long-term care facilities are not designed for the provision of dental care. So dental care is often, clinics, mobile providers come in and set up a clinic in a salon or a chapel or some other kind of, craft room that, where they need to bring in all of the equipment in one day and take it all out in one day, and it needs to be performed, in a hygienic environment and allow, again, providers and patients to be safe and practice in a way that will be effective and efficient. So dental care really, in these settings, doesn't look like dental care does outside of these settings. Among the key findings, and I'll let you, read these for yourselves, there's a few things I want to focus on within this. The first is that dental benefits are largely structured for provision of dentistry to an able-bodied population, and there isn't a lot of accommodation for people who have special needs. That is its own barrier to care. In addition, the regulations that exist around the provision of oral health care to residents of long-term care facilities, this may sound surprising, but there isn't an agreed-upon standard of care for this patient population. Geriatric dentistry is not a recognized specialty under the ADA. Provider training varies a great deal. What people receive, what dental students as well as hygienists and dental assistant staff, the training they receive varies program by program and not even state to state. Your experience at one school in any given state may be very, very different from at another school, or there may be no training at all in geriatric dentistry. Sometimes these courses are elective. Sometimes it's reliant on the student to seek out this population if they're interested in learning more. And because there's not a recognized specialty, the regulations that surround the provision of oral health care are written at the federal level and then supplemented by individual states aren't based on a standard of care. This does create problems insofar as how to structure payment and how to argue for what does a patient really need, what is in the patient's best interest. Medicaid covers almost 65% of patients who are skilled nursing facility patients, but the reimbursement is often too low to cover costs. And types of services that are reimbursed are not always those services that are in the best interest of these patients. So for these couple of things that I focused on here, as well as a myriad reasons I couldn't have fit them all on the slide, poor elderly and institutionalized people often have lower oral health outcomes than the general population. Here we're going to take a look at a map of the U.S. that looks at some of the common procedures that are required by individuals with Medicaid. The map is actually showing you here the types of Medicaid coverage variation on a state-by-state basis. So emergency coverage only, obviously, is the most limited, and this is for adults. Medicaid coverage in the U.S. for adults is optional. Not every state offers it. Those that don't just have emergency coverage. Others have limited coverage with 4 or fewer services per patient, and we consider comprehensive coverage to be 5 or more services available. However, if you look at that list of common procedures for patients in LTC settings, of course we see 5 or more isn't really even stretching the surface. So there is certainly more room to do here in terms of expansion of Medicaid to better cover these vulnerable patients. Taking a look at additional coding options in Medicaid that can help providers to better provide care. There are certain billing codes that are available, but not all states allow them. The map here shows you what is allowed. Teledentistry is available in the states that are marked with stars. This is a technology that allows greater efficiency in treatment of patients when a dentist is not always available. Mobile dentistry facility fee allows more providers to be able to, as we discussed in the Barriers to Care, be able to bring in all of their equipment and make it more financially efficient for them to do that. Allowing a behavioral management fee is another code that allows providers to spend more time with these patients, which, as we already discussed, require, more time for ergonomic as well as safety and best practices. And then for some patients who are particularly restive or they have more extensive oral health needs, sedation is another tool that providers can use to help them deliver a higher quality of care to these long-term care residents. So sort of to summarize our findings, a number of policies and practices would really assist in the provision of care to long-term care residents. Workforce policies that enable services for long-term care residents, including consistent standard of care in geriatric dentistry, greater scope of practice for hygienists in terms of billing abilities, as well as their ability to work independently from dentists, are all policies that help increase access to care for this population. Care configuration, including interprofessional practice, mobile services, and teledentistry, also allow greater access to care for this population. Payment policy reform that assists in serving this population would include a Medicare dental benefit, which currently doesn't exist, Medicaid adult dental benefits, as well as reimbursement structures that encourage safety and effectiveness in dental care for geriatric patients. The best practices that we found in our interviewing were a high level of coordination between different types of providers. In order to get dental care for these patients, many of them are unable to consent for themselves. So the process of even, getting a dental service, making sure that the patient has insurance that will reimburse, doing the billing, getting the consent, scheduling the patient, having them ready for their visit at the time of that either dentist or hygienist is available. All of these different things are things that have to take place on behalf of the patient, and a lot of it prior to the dental appointment. And so this level of coordination of care, even recognizing that a problem exists and the patient needs to be seen, these are things that require a great deal of teamwork across different healthcare provider types. And finally, the will of policymakers and public payers has to be mobilized in order to make these changes. When we have strong advocacy groups and, family involvement, policymakers involved, that is when we really see that there's a great deal of potential to assist these patients in their oral health care. So, Margie, with that, I can turn it back over to you.
So obviously, as an Oral Health Workforce Research Center, we are really interested in workforce innovations to increase access to oral health services. And I would tell you that in the past few years, the main innovations have been in expanding practice for dental hygienists and dental assistants. And of course, as we do that, and when I say expanding scope of practice, I mean that dental hygienists are permitted to provide certain services within their scope of competency at lower levels of supervision, and they are also allowed to do them in public health settings. The question arises among policymakers and clinicians whether or not these workforce innovations are actually effective. So one of the things that we did 15 years ago under a different cooperative agreement with HRSA was we built a numerical scope of practice index to quantify the variation in scope of practice permissions for dental hygienists in all 50 states. And the actual structure of this scope of practice index is very lengthy and not particularly interesting, except that I would refer you to the report where you can read about it on our website. But let me explain briefly that within this scope of practice index, there are somewhere well over 50 or 60 variables grouped under 4 categories. They are regulatory, things like whether or not dental hygienists sit on state boards, levels of supervision in public health settings, such as schools and mental health facilities and long-term care settings. The tasks permitted, and that tasks included things such as prophylaxis, whether or not it needed to be provided under direct, indirect, or general supervision. Again, another layer within the scope. And the last is reimbursement for services. It's very difficult to provide direct services if you can't get directly reimbursed. So this scope of practice index was created in 2001. Scores in the states ranged from 10 to 97 at that point. In 2014, HRSA, under our cooperative agreement with HRSA, one of the projects selected was to update the scoring on that index to determine how scope of practice had changed for dental hygienists in the intervening 15 years, and to also determine whether or not scope of practice actually impacted oral health outcomes. Now, we rescored the index in 2014. I will tell you that the scores, the minimum score changed from 10 to 18, the maximum score changed from 97 to 98. However, the change is more noticeable when you look at the mean score. The mean score increased by 10 points during that period, meaning that many more states progressed to more favorable practice environments that allow dental hygienists to work in public health settings unfettered by direct supervision. We found when we did the update that some states remained high scoring. Obviously, if they were high scoring, they remained high scoring. Some states noticeably advanced. There are several examples of states that moved by creating public health dental hygiene, for instance, or advanced dental hygiene practice in their states. Some states lost ground simply because a provision, for instance, for reimbursement might have been changed and it was no longer available. One of the changes that we noticed is that most states now recognize public health dental hygiene practice in some form or another. In some states it's quite restrictive to education only, and in others it involves everything up to interim therapeutic restorations. So we also use the scores on this dental hygiene index to regress it with outcomes measures in the behavioral risk factor surveillance system. And I will tell you briefly that in 2001, we found that, in fact, higher scopes of practice or more autonomous scopes of practice for dental hygienists impacted utilization, whether or not patients actually accessed any dental services in the year. In 2014, we found that higher levels of scope of practice actually impacted oral health outcomes, measured by having any teeth removed due to decay or disease. One of the outcomes from this last study was that we realized in scoring that the variables that were selected for the index were things that were envisioned in 2001, and in many states, what had been envisioned is now reality. So this year, one of our projects in the coming year will be to build a new scope of practice index that will include different variables. For instance, atraumatic restorations, which were really just burgeoning at the time, 2001, are now much more commonly available and are being used in many settings. So that will be a feature. Things like the need for dental hygienists to supervise a dental assistant to place sealants. lasers, which were not even imagined back in when the first Scope of Practice Index was created, will also be included in that. So you can watch for that forthcoming report probably by the first of next year. Another study that we did in the first year was we looked at dental assisting. Previously, dental assistants had really been treated in regulation and legislation mainly under dental delegation. Dentists were able to determine what a dental assistant could do based on safe and competent practice and on the training, whether or not there was formal education on the job training for dental assistants. We wanted to understand how dental assisting practice had changed. So we did a study looking at all the literature on outcomes from dental assisting clinical practice. We also looked at all of the state law and regulation about dental assistants. And what we found was that, in fact, states are now addressing dental assistants much more commonly in dental practice acts than they had in the past. And the way that they're addressing them is by expanding functions for dental assistants. There's still little convergence across states in how dental assistants are treated. There are over 40 different titles for dental assistants, for instance, that are being used by states. But there are now some emerging standards for expanded function practice, such that many states are now requiring that dental assistants take CODA-accredited courses in preventive functions or restorative functions or orthodontic functions and go through competency testing and certification in order to be able to do them. One of the reasons that FTAs are of such interest is that the literature suggests that they can be used to increase efficiency in practice and therefore capacity in practice. So that, for instance, a dentist may be working with 2 patients at the same time. He can begin drill the tooth and have the FTA complete the restoration while he goes into the next patient. So there is substantial literature suggesting that there are not only economic efficiencies, but capacity increases through the use of FTAs. One other workforce strategy that we've been very interested in is the integration, again, of oral health, the training of primary care clinicians to provide oral health clinical assessments. Physician assistants have been at the forefront of this practice. We did a survey of physician assistant education programs and found that 78% of those education programs include specific curriculum on oral health. All of those, almost all, provide some didactic instruction, and a good portion also provide clinical training. There's lots of interprofessional training opportunities going on with PAs, nurses, social workers in oral health. And the federal government is quite interested in interprofessional training opportunities because it obviously fosters integration. And so this year we're doing a current study of PAs, a survey of PAs who graduated from education programs in 2014 to understand whether or not they're actually putting oral health assessment into their clinical practices. So quickly, I'm going to just, because we're running out of time, we, as a Center of Workforce Studies, have also done some very specific work in states, and I thought I'd just pick a couple of states that, to us, show some very interesting innovations. Probably the state that has done the most for workforce innovation is Maine. And I think that Maine has some very significant problems with rural populations in remote areas, and they recognize that they needed to have a menu of possible workforce configurations to allow for local solutions. So one of the major innovations is that they have built a dental school at the University of New England. Half of the dental class that entered in 2013 is from Maine, New Hampshire, or Vermont. So the first graduates will be in 2017. In addition, they've enabled several kinds of practice for dental hygienists, a basic traditional dental hygiene practice, public health dental hygiene practice, independent dental hygiene practice, and dental hygiene therapy practice. They also have expanded function dental assisting. Dental hygienists can bill Medicaid directly. So there are lots of opportunities for oral health workforce to have very creative practices that address the needs of local populations. Another state that sort of came to our attention was Michigan. They have both very interesting workforce policy. Currently they're considering a dental hygiene therapist or a dental therapist. They also have a public health dental hygiene program. that's been amazingly successful in working with both children and adults. In just 2012 and 2013, public health dental hygienists saw more than 30,000 children and more than 5,000 adults through these practices that are in sort of clinics and non-traditional locations, including mobile dental vans and migrant farm worker programs. Michigan contracted with Delta Dental to manage all dental services for Medicaid-eligible children, and again, a very successful program that's being replicated across the United States because they were able to leverage an existing panel of private practice dentists who participated with Delta Dental who would now accept Medicaid-eligible children because of the eased administrative and credentialing processes. And they've been able to show sustained utilization growth among children on Medicaid in that state. Some of the local solutions are listed here. I'd just like to point to one that was particularly interesting because to me it always points out the usefulness of local initiatives. In Calhoun County, which is where Battle Creek, Michigan is, a local community service agency created a Pay It Forward oral health access program that has been extremely successful. It engaged dentists to provide services at a minimum cost or on a volunteer basis, and it required that patients who were uninsured had to work a certain number of volunteer hours in any community agency or any not-for-profit in order to gain points to get free oral health services. I asked one of the people in that initiative about whether or not everyone could volunteer, and she said, do you know, I was not convinced that that could happen, but she said, I had one patient who was a diabetic and a double amputee, and she chose to knit all of the caps for the babies in the birthing unit at the local hospital, and that's how she earned her oral health services. So I encourage you to look at that online. It's been very successful, although perhaps not replicable in all communities. And Cynthia, do you want to talk a little bit about California?
Thank you for sharing that. I want to take up knitting now. Looking at California really briefly, there are two really important innovations that have happened there. The first is the virtual dental home model that I'm sure many of you are familiar with, or at least have read about or heard of, and that was, envisioned and spearheaded by Dr. Paul Glassman. It allows dental assistants and hygienists, along with other allied providers, to use store and forward technology for digital images of a patient's oral health to send to a dentist for analysis and diagnosis. Because the dentist can diagnose from a distance here using this, kind of teledentistry, digital dentistry model, the hygienists are able to treat patients to the full extent of their scope under the direction of the dentist, but without the patient ever having to see the dentist. So, we're increasing the speed at which patients are seen, reducing the cost, reducing things like, patient having to take time off work, to get a child, for example, to the dentist, and improving the efficiency of care overall. The second innovation is the registered dental hygienist and alternative practice. Again, I'm sure a lot of you will be familiar with this, but what it allows is independent practice of hygienists in a collaborative practice model with dentists. So they can work, again, without direct supervision. The dentist doesn't need to be there. When their work must be performed in underserved areas or with underserved populations. So this is another provider who's increasing access to oral health care for the long-term care residents. But they also work in, rural environments. Schools are another example. And both of these programs, not programs, I'm not sure it's the right word, but these innovations, the virtual dental home as well as the RDHAP came into existence in California under the California Health Workforce Pilot Program, which is a mechanism through the state Department of Health Services that allows changes or new concepts in healthcare delivery to be tested and evidence to be gathered before a legislative change is put forward. So this just allows an exemption under existing scope of practice to test the new concept, and then having proven itself successful, it can come before the House and Senate at the state level for legislative change. So I'll pass that back to Margie.
Thanks, Cynthia. Let me just say that, as you can probably tell, we're pretty passionate about our work. I think that helping people understand what the access issues are and what some of the strategies might be to address these issues are really important to us. Many times I feel like primary care gets put in the spotlight a lot, and we lose track of oral health access. I think that there are many stakeholders who we want to engage with regard to our work, including federal government, state planners and policymakers, oral health professionals, providers, associations, consumer advocates, coalitions. But so these are the people who we think it's so important to know about our work and understand what strategies are happening. Because again, I think we don't put enough of a spotlight on some of these efforts. So here are some of the things we're looking at for the future. Looking at dental service organizations, which is a rapidly growing phenomenon, and trying to understand better their capacity to increase access to services. Looking at mobile and portable dentistry programs, again, as it relates to underserved populations. A study of Hispanic dentists to better understand their practice patterns and their contributions to expanding access to services. And finally, looking more closely at FQHCs and the resources that are being invested to support their expansion of capacity. The other thing I just want to share with you, and this is something you can find at the end of this, is links to all of the reports we've done. So there are some reports that are posted to the Oral Health Workforce Research website, and they're listed below. More obviously will be coming. There are other reports that you will find on the Center for Health Workforce Studies website, and here they are listed with links to the reports. You can feel free to email me, Margie, or Cynthia about any questions you have.
With that said, I already have a couple questions I've received. First question, are many states showing interest in emerging professions such as dental therapists and dental hygiene therapists?
I think there's growing interest. It's important to recognize that these changes happen state by state. And in fact, I would say we know a number of states that have been attempting to create some of this capacity for a few years now, and it obviously requires statutory change, and sometimes that can take a while. Margie, do you want to say any more about that?
You know, creating a new profession, which is, you know, in oral health, it's being referred to as the mid-level oral health provider, although many of you will find that disagreeable, just as clinicians in oral health, in regular healthcare don't like to be called mid-level. But it is a mid-level model because what it will do is integrate the ability to provide both preventive and basic restorative services. Some of you know that Alaska was the first to use this model in tribal communities in remote regions of the state. It was the only state in the continental U.S. that followed was Minnesota, and they created two different models, one which was an entry-level education model and another that included, was built on a dental hygiene education model. That dental hygiene education model seems to be the one that states currently prefer. That is taking a dental hygienist who is already licensed, providing them with further, more extensive education in restorative services, and creating what's called a dental hygiene therapist. That's the legislation that was passed in Maine and in Vermont. Massachusetts was recently considering that legislation. It was, however, not signed by the governor. I think Michigan is considering it, and perhaps Kansas. So there's movements in legislatures right now to use a dental therapy model, oftentimes based on dental hygiene practice. And we're seeing that interest is increasing over recent years.
Okay. Next question. How much of the underserved population are FQHCs able to currently reach with dental services?
That's a really interesting question. We've seen from the numerous site visits we've conducted with FQHCs that resources can really constrain their capacity. So while they may be able to expand services, it's probably greater than the populations who are in need of those services. So I think that, you know, they are a key safety net provider that can play important roles, but I also think we need to understand kind of the limitations of the resources that safety net providers have to work with to enable access. The other thing I will say is there are some populations that are much more challenging. So, you know, to Cynthia's point about access to services for people in long-term care, another high-need population with very limited access are special needs populations. Margie, do you want to say a little more?
Yeah, I'd encourage you to go on to the publicly available data set, the uniform data set collected by HRSA that describes both primary medical care and oral health service provision in FQHCs. That is available on their website, and it would give you numbers. There's some very interesting literature suggesting that in the past we've relied heavily on the safety net to provide services to the underserved. And although that's a reasonable reliance, we have to recognize that the capacity within the safety net is extremely limited. They're publicly funded. Some have to rely heavily on philanthropy. So it's impossible for them to actually provide all the services. And to consider that, 95% of dental services that are provided in the United States occur in private dental practice. So we need to find a way to engage the private practice community in providing services to the underserved. That said, HRSA just provided $156 million to almost, I think it was 400 FQHCs, wasn't it, across the U.S. for expansion in dental capacity, meaning hiring workforce, expanding existing facilities, or building new dental clinics. So we're going to continue to see expansion within the federally qualified health centers in their ability to provide those services. But again, we need to depend heavily on private practice dentists because that is very important, and the majority of where oral health care is provided.
Okay, thank you. And I have one more question here I want to make sure I get in. Cynthia, I believe this one's for you. Is there any evidence that those optional billing codes can really improve access to care?
Yes, the answer is yes. Unequivocal. Can these things improve access to care? The mobile dentistry is a huge thing, in terms of allowing, access. This is certainly, I was talking about access in long-term care facilities, thinking about, access for schools, population health. Mobile dentistry is just big and getting bigger. This concept of bringing care to the people, and that one is giant. In terms of behavioral management, teledentistry also, yes. Behavioral management, I think what I would say about that is that, a lot of times fee structures under Medicaid, I think I had this on the barriers to care slide, they aren't even sufficient to cover the cost of service provision for the provider. So a lot of providers, they're cross-subsidizing from other practices or using kind of philanthropy to fill the gap. And sometimes fees haven't been updated in 15 years or 20 years while the cost of technology certainly has grown. So a lot of these kinds of tools for the provider really just get them even closer to a break even. They can encourage providers to go into this subset of patients who may have not been willing to or unable to financially without these billing codes. And they also have the potential to improve access from in a structural way as well. So these can all improve access to care, and I'm sure that there are a number of other codes that states can explore in order to continue to increase access to care. Jean, did you want to add anything?
No, again, having done some work looking at teledentistry, it's very clear that it has tremendous capability to help bridge the gap and improve access, so we agree.
Okay, well, thank you, Cynthia. Thank you, Margie, and thank you, Jean. That was really interesting material. Clearly, there's a lot to discuss. And thank you out there for attending our webinar. Just to let you know, we will be posting our slides shortly to our website. So if you want to download them, check back very quickly at healthworkforceta.org. We hope to see you again in the future. Thank you, and have a good day.